And I would now request Dr. Rajannarayanan to introduce our next speaker.
Manoj, the plan is to go straight till the end.
Hello everyone once again. It is my pleasure and honor to introduce Professor Gillian Leng, who is the Chief Executive of National Institute of Excellence, National Institute for Health and Care Excellence, which is popularly known as NICE. So NHS is, the NICE is part of the Department of Health and Social Care of UK, and it guides NHS England and Wales based on evidence for efficacy, safety, and cost effectiveness. Professor Leng, as a junior doctor, was struck by variations in clinical practice, and she developed this into a passion for using evidence to improve care. She trained in medicine at Leeds, worked on clinical trials and epidemiological research in Edinburgh, and was a public health consultant in London. She was also an editor of the Cochrane Collaboration and is now the chair of the Guidelines International Network. I welcome everyone to listen to this pre-recorded talk of Professor Gillian Leng.
Hello, I'm Gillian Leng, and I'm delighted to be here to give you some background to NICE, what we do, how we do it, and why it matters. I've been at NICE since 2001, so not quite since the start, and I'm only the second chief executive, taking over from Andrew Dillon on the 1st of April 2020, which wasn't the easiest time at the start of the pandemic. And I've had a career that's all been about evidence-based healthcare, and NICE plays an important part of that story. Our role is to improve health and well-being by putting science and evidence at the heart of health and care decision-making. This slide gives a number of reasons as to why NICE was originally set up in 1999. There were many reasons, but particularly the one in the middle, that's the one I'd like to highlight. Number 4, variation in the nature and quality of care, the postcode lottery. There were local mechanisms deciding at that point on the cost effectiveness of new drugs, but this created variation in what people could access, what treatments you could have, which depended on sometimes which side of the road you lived. And that was very much seen as unacceptable by the public and therefore by politicians, and hence the reason why NICE was put in place. Here is a very high-level overview of some of the key things that have happened at NICE since we were established in 1999. And over that time, we've built a world-class reputation as an international leader in technology evaluation. We began with technology appraisals in 2000. We produced guidelines from 2002. We took on a public health role in 2005, social care in 2012. Lots of things that aren't shown on this slide have indeed happened. But this year, 2021, an important year as we've published a new strategy for the future. All been about evidence-based healthcare, and NICE plays an important part of that story. Our role is to improve health and well-being by putting science and evidence at the heart of health and care decision-making. This slide gives a number of reasons as to why NICE was originally set up in 1999. There were many reasons, but particularly the one in the middle, that's the one I'd like to highlight. Number 4, variation in the nature and quality of care, the postcode lottery. There were local mechanisms deciding at that point on the cost effectiveness of new drugs, but this created variation in what people could access, what treatments you could have, which depended on sometimes which side of the road you lived. And that was very much seen as unacceptable by the public and therefore by politicians, and hence the reason why NICE was put in place. Here is a very high-level overview of some of the key things that have happened at NICE since we were established in 1999. And over that time, we've built a world-class reputation as an international leader in technology evaluation. We began with technology appraisals in 2000. We produced guidelines from 2002. We took on a public health role in 2005, social care in 2012. Lots of things that aren't shown on this slide have indeed happened. But this year, 2021, an important year as we've published a new strategy for the future. This slide sets out the formality of what NICE is required to do. And as you can see, our remit is quite broad, producing guidance plus quality standards plus recommendations on a whole range of other types of evidence-based treatments across public health and social care and healthcare. But importantly, there are clear implications of our work for our healthcare system. There are requirements for certain public bodies to have regard to what we've said in the way they carry out their work. And importantly, in relation to technology appraisals, when we recommend a drug, commissioners must make funding available for those drugs within 3 months. And that really makes a difference for patients in terms of access to those drugs. This slide outlines how NICE fits into our National Health Service. You'll see Parliament at the top with ultimate accountability and NICE over on the right. And we issue advice primarily to the local system, community health services, primary care and hospitals and foundation trusts. And what isn't shown on this slide is the work that we do is generally commissioned to us from NHS England. That's the body that runs services across our NHS, and the Department of Health and Social Care. So we get formal commissions for the work that we do around drugs and guidelines, and then we send it directly out to our local service providers. There are 13 key principles that underpin all our work. You can find these on the NICE website, and that's the same whether it's looking at a new drug, a drug appraisal, guidelines, or quality standards. And in brief, these are about reflecting national priorities, clearly describing how we do our work. It's all set out in manuals on the NICE website. We work with independent committees to develop our recommendations. It's not just a group of us sitting in the NICE offices. We consider advice and experience of a wide range of people, and we always offer an opportunity to comment through consultations. We use whatever evidence is relevant, and then we make recommendations based on an assessment of population benefits and value. We support innovation where we can, where that is good value. We aim to reduce health inequalities, and we also propose new research questions, encourage adoption of our recommendations, and regularly review and update what we do. So a comprehensive work programme in what you might call the evidence ecosystem. And as an organisation, we also have a set of values and behaviours that underpin our work. The lower ones are internal for our staff, and the 3 at the top reflect our approach to work: excellent, collaborative and dynamic. And you'll see those words again in the new NICE strategy. Another way of describing our work is in 3 ecosystems. The first one is the life sciences ecosystem, which is about evaluating new technologies, primarily to determine funding decisions. It's very much about what's value for money. We also look at new interventional procedures, specifically around safety. Now, the guidelines ecosystem is probably the biggest, and it's an ongoing one, hence the little circle here. And we produce guideline recommendations for frontline practitioners on big topic areas, things like depression or maternity services. And there's an ongoing cycle there because the evidence is always being renewed and refreshed. And there's something also called the information ecosystem, where we provide advice on things like prescribing, and evidence in the broader sense, a search facility on the website. These ecosystems all join up. This is a schematic diagram that illustrates how you go from horizon scanning for new drugs through our evaluation to issuing guidance, then feeding that through into a guideline along with information on prescribing from products like the British National Formulary. So a complex array of work. It does all need to join up, and the guideline is the end point that frontline clinicians primarily refer to. So that's set out the context of what NICE does and how we work and how we fit into the system. Now I want to talk to you a little bit about the future. As I said earlier, we have just launched a new strategy for NICE in April this year, developed, of course, during the beginning of the pandemic. So it's a testimony to the work that can be done virtually and how you manage to network genuinely across the globe. And as we developed the strategy, we did indeed talk to people around the globe because we wanted to find out what was changing in the environment. We identified 6 key challenges. The first of these was the rapid pace of innovation in health and technologies. So many new things coming online, so many things related to genomics, advanced therapeutics, all sorts of digital products that we need to take into account. Secondly, an absolute revolution in the availability of digital products and data that we might use in our evaluations. Thirdly, in the UK particularly, there's integrated care systems being established, which is getting rid of the traditional barriers between healthcare and social care. Fourthly, we saw a lot of increased collaboration during the pandemic, and we need to continue to build on that. It's been great to work with colleagues, all with the common endeavour of COVID. And of course, the UK has now left the European Union, and there are implications for our international work that link with that too. Fifth, the pandemic shone a sharp light on health inequalities, and we need to make sure that our work can help tackle health inequalities wherever possible. And 6, economic challenges for our healthcare service, economic challenges for NICE, economic challenges again around the world, not helped by the pressure of the pandemic. So a number of things there that came through as we had these conversations around the world. And taking all that into account, we looked at where NICE should focus its efforts over the next 5 years to have the biggest impact. And the strategy sets out 4 strategic pillars. The first is rapid, robust and responsive technology evaluation. Second is dynamic living guideline recommendations. The third is effective guidance uptake to maximise our impact. And finally, leadership in data research and science. And I shall say a little bit about each of these. So, technology evaluation. Our ambition is to continue to be at the forefront of anticipating and evaluating new emerging technologies. That's because we need to not just provide world-leading assessments of value, not just to prove how good we can do this stuff, but very much to improve access for patients. Some of the early priorities in this area have been to launch a new Office for Digital Health Technology Evaluation, explore how we might have some sort of contingent approval mechanism for medtech and digital products. And that means where we haven't got enough evidence now, we say, well, let's approve it for use and continue to collect the data so we can take a more robust look in the future. As I said, we want to look at our methods that focus on inequalities. We want to develop our international partnerships, and we are going to develop an online life sciences hub to make it easier to bring all of this work together to help our audiences and guidance users to find the information they need. The second was dynamic living guidelines, and We need guidelines that are useful, usable and used to support evidence-based practice. And again, fundamentally to improve people's lives and address health inequalities. The pandemic and the development of guidelines for the pandemic gave us a great opportunity to produce living guidelines. We obviously didn't have much evidence at the start of the pandemic to develop guidelines at all. A lot of the recommendations were based on consensus. However, as the evidence base has continued to grow, we have very rapidly looked at that and built it into the guidelines with regular rapid updates. And that type of approach, a living guideline, is what we need to achieve in the future. And to do that, we need to focus our guideline portfolio. At the moment, there are about 400 different topics, and we need to bring those together in some core areas of work so that we can manage this living guideline approach to guideline development. We will need a new digital guidelines platform to house the guidelines to make that process easier. We will need new mechanisms to gather feedback that's not just published research, but also data and information from professionals and the public. And again, we will need to update our manual to show how all of this is going to work and how we will include data. The third point is effective guidance. Uptake, clearly a crucial ambition, because there's no point at all producing wonderful evidence-based recommendations if they aren't used in practice. And we will need to do this by working with partners around our healthcare system, because collaboration is what's going to make the difference here. And early priorities are particularly around supporting patient safety and looking at where we can reduce inequalities and looking at the barriers to adopting technologies. All of that absolutely requires partnership working. Finally, leadership in data research and science. We want to very much continue to be scientific leaders driving the research agenda and thought leaders at the forefront of developing innovative approaches to using real-world data and data analytics. We've already done a lot, because when NICE was originally set up, we very much relied on published research. But now there is data everywhere being collected in our healthcare system all the time, and we need to harness that, and we need to set standards for using real-world data in our decision making. We need to work with partners to establish large data collection activities, especially where we've identified gaps in the evidence, so we can feed that through to either formal research or to data collection. We want to launch something called NICE Listens, which is a new approach to understanding what the public considers important, rather than stakeholder groups, groups of patients, our committees. This is a genuine public feedback exercise, and the first question we're going to ask is very much about health inequalities and how NICE might help. And the final point on here is crucial, bearing in mind that the climate change agenda at the moment. We want to consider how we can support that through our work on technologies. Technologies are wonderful things. They've absolutely changed our healthcare, but they do have some impact on the environment, whether that's in waste, water use, energy consumption. And we should publish that information, and we should encourage manufacturers wherever possible to look for more sustainable ways of developing new products. So bringing that all together, our vision for NICE's future is to be at the forefront of anticipating and evaluating new and existing technologies, providing these dynamic living guidelines that I've talked about, being scientific leaders so we can drive the research agenda, also drive the uptake of our guidance to improve care for patients, and underpinning all of that, obviously, there's a transformation agenda for our organisation to make sure we've got the skills and capacity in place. And finally, I want to talk briefly about NICE International. The aim of NICE International is to support countries to improve their own nation's health and well-being. And we do that by sharing best practice and experience from NICE. And we also want to gain learnings and from international partners as we do that to help shape our work at NICE. And we do this by providing advisory services, be that to individual organisations, to ministries of health, to government agencies. And we want to share our own best practice and best practice across the globe to help drive improvements in health and social care. And we do this in line with the UN Sustainable Development Goals and the UK Global Health Ambitions. And this all happens on a fee-for-service basis. The NICE International Service offering can be divided into 3 types. And these three service offerings cover all aspects of our work, and that's an important point to emphasise. So it's not just evaluation of drugs and technologies. It also includes guidelines, policy implementation, and it covers health, public health and social care. So the first of these offerings is knowledge transfer, seminars or workshops. And often in the past, we've travelled around the world to deliver these, but of course that's not so straightforward. So we have a very good webinar offer at the moment. We can do these virtually, and they are very much tailored to what people want. They will vary in length depending on needs. They might be focused on one area or vary in detail and the complexity. The second thing is a scoping exercise, a two-way discussion to understand what the issues are, to analyse the current state, and then to work out what capacity and support might be needed. And that might be an initial piece of work that we do, ending perhaps there and then, or ending in a programme of further support. And finally, there is other types of consultancy and support that we can offer. And this might be capacity building, it might be pilot projects, it might be ongoing advice and support. It very much depends on what is required at a local or country level. And here on the left of the slide, you can see some of the NICE International team members. And some examples of the work that they've done include consultancy services about our health technology assessment work through the Foreign Commonwealth and Development Office, and a programme in Brazil, South Africa and the Philippines. We've done some knowledge transfer work by sharing knowledge on health technology assessment with organisations across Latin America and the Caribbean. And we've done a whole range of speaking engagements about adopting new technologies. For example, the work that we did in South Korea with their HTA agency. Now, those are just some examples, and they've focused on health technology assessment. But as I said earlier, the NICE International team will cover all of the work that we've done. If you remember those 3 ecosystems: technologies, guidelines, and information services. And I'd just like to flag up now the Executive MSc in Evaluation of Healthcare Interventions and Outcomes. Rather a long title, but that delivers training in health services research, health economics, health outcomes research and health policy. And it's designed to further develop people's skills in advisory, management and leadership roles across the health sector. It's a 2-year programme of full-time work. And it's a new programme that NICE has set up in collaboration with the London School of Economics and Political Science. You can apply now if you are at all interested. It starts in November 2021, and there's a web link here. So finally, thank you for listening. I'm sorry that I can't answer any questions directly today, but please do keep in touch if there's anything you'd like to follow up, either with me personally or through the NICE International team. And I do hope you found it useful. Thank you very much.
Thank you, Professor Leng, for giving us a glimpse of NICE's mission and ongoing offerings. We will now go ahead and play a short video for all of you that calls for submissions for the IHOPE Journal of Ophthalmology. And after this, we will take a short 5-minute break and be back 7:15. We will be back on.
Hello everyone, I'm Dr. Rajannarayanan. I would like to introduce the Indian Health Outcomes Public Health and Economics Research Center, which has been founded with the grant from India Alliance, and we are a collaborating institution between Indian Institute of Management Ahmedabad, Public Health Foundation of India and LV Prasad Institute. We are having this annual conference of IHOPE on September 11th, which is focused on research to policy. So those of you who are interested in healthcare and are doing research in the areas of public health and health economics, this would be a great feast for you all. Thank you very much. I look forward to seeing you all.
Hello, I'm Dr. Anthony Pandas, a co-investigator at the Indian Health Outcomes, Public Health and Economics Research Center, which is a multidisciplinary collaboration between the LV Prasad Eye Institute, the Public Health Foundation of India and the Indian Institute of Management, Ahmedabad. Data is the new oil, or is it? Join us for the first ever IHOPE conference to know more about the potential and challenges of big data in healthcare in India. We look forward to seeing you there. Join us on the 11th of September at 5 p.m. at the first ever IHOPE virtual conference. See you there.
Hi, I am Professor GBS Murthy. We have been actually working together as a collaborative team with the LV Prasad Eye Institute at Hyderabad and the Indian Institute of Management at Ahmedabad, which looks at health outcomes, public health and health economics, looking at three broad verticals: big data, public health and health economics. This is something which is fascinating, has never happened before. How do we use research findings to improve the quality of life of populations for whom we are serving? And that is leading us on to the first ever conference. Be there, because this is something which is unique, fascinating, and I'm sure you will enjoy it to the hilt. Cheers.